All right, so when we are looking at some of the other adverse effects that are worth monitoring for Alzheimer's disease and cognitive impairment, over time we see behavioral disturbances. And typically, behavioral disturbances can be quite challenging to manage and can be a result of a patient that has a need that was unnoticed or unmet by their caregiver. So because communication and social skills might be a challenge for that individual, they may engage in sort of acting out type behaviors to try to address their unmet needs. So things that can cause this, of course, include things like environmental stressors. There's often a reduction in their ability to tolerate stress, so their resilience has gone down, and that can result in those behaviors. So these are called behavioral and psychiatric symptoms of dementia. And really, when we're assessing and managing these symptoms, we can see things like wandering, like striking individuals, right? Like acting out type scenarios, right? That can be really distressing for both the patient and the caregiver. So we want to make sure that they're safe, number one. And we want to think about like who they are when they don't engage in those behaviors. So what's their baseline? How do we assess and determine how they're doing compared to how they typically do? We always want to think about reversible causes. So do they have UTI and they're delirious? Do they start a new medication and they're experiencing adverse effects? Or are there other things? Maybe their hearing aid batteries are dead, right? So we want to think about what types of factors might be contributing to the behaviors that we're noticing. When we're managing someone who's experiencing BPSD, we want to try to not use medications because the risk versus benefit gets a little bit challenging there. So first line is non-pharmacological management. So redirection to activities of interest, providing social support and social interactions, finding things that are comforting to the individual. Maybe it's therapy animals or, like a heated blanket or whatever. And if it's milder, if their behaviors are milder and they have the ability to engage in things like talk therapy or cognitive behavioral therapy, we're going to try to engage those as well. If safety is a significant concern and the individuals don't respond appropriately to those non-pharmacological interventions, then we can potentially use antipsychotics. So these are the most common antipsychotics that are utilized for this indication. So risperidone actually has a fair amount of data for our older adults. Haloperidol has more historical data, but we can use quetiapine, olanzapine, aripiprazole. Their general recommendation, especially with CMS monitoring and recommendations, is to try to use it as briefly as possible. And really in situations where safety is a concern, if someone's swinging punches, if they are having a real hard time maintaining safety for themselves or others, then antipsychotics might be appropriate in that situation. So safety, right? We want to try to use the lowest effective dose. So we probably will really start near the bottom and then creep our way up. Don't worry too much about these dosing recommendations. Really thinking about trying to use the lowest effective dose is the most important key. We want to monitor closely for efficacy. We want to monitor for tolerability. And of course, that boxed warning still applies if it's dementia-related psychosis, that there is that increased risk of mortality. Brexpiprazole is an antipsychotic that recently got approved specifically for dementia-related agitation to be taken daily. It's kind of an interesting quagmire there when it comes to having those specific indications, but we can potentially utilize these antipsychotics. So again, take home for that, non-pharm first, right? Reserve for cases for harm or significant risk with continuous reevaluation, and if possible, reduction or discontinuation within 12 weeks. So to wrap all of this up, Alzheimer's disease is a pretty prevalent illness in our older adults that has significant burden on both the caregivers, the healthcare system, the economic system, and the individual. We want to see what kinds of things we can do to try to prevent worsening, to manage those symptoms, but we do have some interventions that are medication-based that can help to slow progression, and potentially even modify the disease. Those monoclonal antibodies, they are emerging. We don't know for sure 10, 15, 20 years down the road what their role is really going to be in benefiting individuals identified with mild cognitive impairment. But it's an exciting time for treatment because we really have been hoping for a curative or a treatment that doesn't just slow our progression, right? Because a reduction of, less than 2 a year is great, but still means that there's progression of the illness.